Hi, this is Jamie Levine with Elder Law and Advocacy. I have today the honor of speaking to a former Elder Law and Advocacy employee, Tony Chicotel. I worked with Tony for a number of years, and he has since moved on to work with California Advocates for Nursing Home Reform and to do a master's in public policy, I believe it was. Is that right, Tony?
Yep.
Yeah, master's in public policy. He's a fantastic attorney, and it was amazing to have worked with him. And I'm going to be discussing with him a project that he has been working on regarding the use of chemical restraints in nursing homes. So without any further ado, Tony, can you tell us a little bit more about yourself and what you've been doing with this project?
Okay, well, I work in San Francisco and live in Berkeley, California now. I've been at California Advocates for Nursing Home Reform for the last 6 years. A couple years ago, I can't really remember what the impetus was, but one of the big issues with nursing homes for almost 35 years now has been the overuse of psychotropic drugs on the residents. And a couple years ago, I started becoming more interested in those kinds of cases. There's a lot of rules about prohibiting the misuse of the drugs that weren't being followed, and I wanted to do something about that. So I talked with my staff here, and we came up with a website. It's canhr.org/stop-drugging. Hopefully you could run
Yeah, I'll post that
on that. And we started a website. It was all about initially community education, educating nursing home residents, their family members, their friends, and the nursing home providers themselves about some of the issues with misuse. We got some good traction. There's been some notable cases, some really bad stuff going on out there that got exposed. And so the National Center for Medicare Services, CMS, in the Health and Human Services Department got interested, and we had a call with them about a year and a half ago, a bunch of advocates from around the country, and we pressed on them to do more in this area. And since then, they've adopted a national initiative to reduce the misuse of psychotropic drugs or antipsychotic drugs in nursing homes, and also to improve dementia care, which sort of work hand in hand.
Okay. Can you take a step back and describe what chemical restraints are?
Sure. Chemical restraints can be an issue in any facility or even in somebody's home. The idea is that somebody is too active, too agitated, too angry, too resistant to whatever the rules are going to be. And as a result, we're going to give them a drug that will make them more passive, more acceptant, more tolerant, whatever the situation calls for. So chemical restraints are defined as a drug that's used to control behavior. And then also the illegal part in nursing homes is used to control behavior and not necessary for the treatment of whatever the underlying condition is.
Okay. And what is the prevalence of this kind of misuse of those kinds of drugs?
Well, it's hard to put a number on the misuse. We do know that it's pretty rampant. About 60% of nursing home residents in California receive a psychotropic drug of some type, either an antipsychotic, anti-anxiety, or a sleeping drug, or an antidepressant. About 25% of all nursing home residents in California receive an antipsychotic drug. And we've seen studies that show somewhere around 88 to 90% of that antipsychotic use is off-label, meaning not approved by the FDA for that particular use. And I would say somewhere between half to 3/4 of the use could probably easily be described as misuse or not necessary to treat the residents' conditions. One of the things I've learned, especially over the last couple of years, is that there's all sorts of non-pharmacologic, non-drugging options to help somebody who is in distress. In a nursing home, it's often somebody with dementia who is unable to communicate very well, so they use behavior or action to express discomfort or pain or anxiety. And so the idea is really simple. Just make somebody comfortable, make them happy, relieve their pain, and you won't have the action that's causing the problems, and you don't need to turn to a drug.
Well, to play a little bit of devil's advocate, I'm sure some would argue that the best way to make difficult patients or residents comfortable would be to give them a certain type of medication.
I think it's the bluntest way. And a recent study showed that these drugs, claimed that these drugs were effective in reducing the problem behaviors. Well, that's probably the case. They're very effective at making somebody sleepy, tired. I hear the term often, zombie, turning them into a zombie. So if your sole goal is to make somebody sleepy and out of your way and quiet, then yeah, these drugs are pretty effective. If the idea instead is to deal with their underlying problems, improve their quality of life, make them as happy as they can be, then these drugs are really a poor choice. Studies show that their effectiveness is limited, and it's usually superseded by a placebo. It's far superseded by good, comfort-centered, patient-centered approaches to dementia care. And you avoid all the side effects, which are lots of sleepiness, confusion, falls, really horrible outcomes that actually double the risk of death for elderly people with dementia. So an antipsychotic has an FDA black box warning label that says that these drugs nearly double your risk of death. So effective in one way, yes. Best treatment available, certainly not.
Right. Now, I also read on your website, which is actually very interesting and is empowering if anyone is interested in acting on any of these issues. I read that there are some other motives that may be compelling the use of these drugs other than comfort. Do you want to talk about what some of those other motives might be?
Well, before I do that, I just want to mention that on our website we do have facility-specific drug rate information. So you can see any of the nursing homes in California's drug usage rate on antipsychotics, anti-anxiety, sleeping pills, and antidepressants. And you can compare the different facilities, and you can search by county, you can search by facility name. So that's a pretty cool feature on the website. Yeah, there's lots of motivations for the use of the drugs. There's lots of layers to this problem. One of which I think is the prevalent absence of doctors in nursing homes. Every nursing home resident has a primary care physician. It's part of the deal when you come in. But they don't spend a whole lot of time in the facilities getting to know their residents if it's a new doctor. And they certainly don't spend a lot of time, on average, with residents regarding their issues. So typically they're called by the nursing home staff, and certain things are reported to them, and their response is to give a prescription. So the absence of doctors, I think, is one problem. Short-staffed, understaffed facilities tend to have higher usage rates of the drugs, and we think in those situations the motivation on the part of the staff is, well, we've got more than we can handle, and we need something to bring these patients or these residents down a few notches to make our lives a little easier and to handle our workload. So I think one motivation is potentially to substitute the pills for good quality care and additional staff.
One of the core issues here is that people are not given informed consent. Can you say something about that?
Yeah, the typical drugging process in nursing homes that I hear about is where a resident starts to have some issues. It could be caused by pain. It could be caused by confusion because they've been dislocated from their home of 40, 50 years. It may be that they miss their friends and family. It may be that strangers are coming after them and taking off their clothes, the CNAs. So there's all sorts of reasons why this might be happening. So the procedure is typically that the staff will recognize that there's some sort of problem. They'll pick up the phone, they'll call the doctor. The doctor will give them a prescription, either over the phone or will fax in a prescription. And then the drug is started. In a lot of facilities, the culture is that the resident is not somebody who's capable of participating in their care decisions. So they're just a lot of times blatantly ignored. So the prescription will be started, it'll be added to whatever drug regimen they were on before, another pill in the cup, they take it. Some of the better facilities make a point to call family members if they're the decision makers, or talk to residents and get their approval for the drug. But what I find in my experience is a lot of times those staff members aren't well versed on the risks, the benefits, and the alternatives to the drugs. So they'll sell the drug with a very short explanation. Oh, this is to help your mother sleep. This is to help your grandfather because he's been refusing showers, so he'll be more likely to take a bath or a shower if we give him this drug. And most family members say, well, of course we want grandpa to take showers, so we're going to allow you to use the drug. There's no explanation about the black box warnings, that this is an off-label use not approved by the FDA, that there's lots and lots of alternatives. For example, if a resident is refusing showers, you have to look at what the shower experience is like. Is it, what would it be like for you if strangers were coming after you, taking off your clothes and throwing you into some room with the water's too hot? And it would be very confusing, and you probably wouldn't want to repeat that experience. So you'd want the staff to take a good hard look at what's going on with the bathing, bring in the family, try to figure out ways to make the bathing experience a little more acceptable and less scary.
So there are ways to approach this without having to resort to the kinds of psychotropic medications that are in question.
There's almost too many ways to count, too many alternatives to count.
Okay.
There's so many things you can look at. The environment, what's this person's life experience like right now? Is it loud? Is it too bright? Is it too dark? Are they being stimulated emotionally? Is someone there to speak with them on friendly terms? Are they lonely? Are they in pain? You want to do a thorough pain assessment. You want to take a look at, the simple things like their clothing. Are they warm enough? Are they too warm? There's just so many things that you could do to investigate what the cause of the behavior really is and to rule things out before you start turning to a chemical restraint.
One thing you just mentioned was the use, the off-label use of medication. Can you expand on that, on what that is? Sure.
So all the drugs that Americans use are typically approved by the FDA for a specific use. In the case of antipsychotics, it's specifically approved by the FDA for use in psychosis or bipolar disorder. It is not, however, approved for the use in dementia. A lot of drugs are used off-label. There's all sorts of examples in the non-psychotropic drug world where the FDA approves the drug for a particular use, and doctors or healthcare practitioners find that it's also beneficial in some other use. Well, doctors are allowed to prescribe drugs off-label. The key is that the drug companies aren't allowed to promote that use. That's considered off-limits. But generally, if a drug is being used off-label, most people want to know. And so we don't say that drugs shouldn't be used off-label. We just say that the consumer and the patient should have that information, and hopefully it will raise at least a yellow flag for them that maybe I need to do a little more investigation of whether or not this is a good use.
And have there been cases where pharmaceutical companies have been marketing these drugs as chemical restraints, or is that just doctors taking it upon themselves to apply it that way?
No, there's tons and tons of cases recently where the pharmaceutical companies have been prosecuted by the federal and state governments for marketing off-label illegally. And now the pharmaceutical companies have displaced the defense industry as the biggest defrauders of state and federal governments in the country. I think in the last 2-3 years, we're talking somewhere between 10 and 15 billion dollars. That's billion with a B, in penalties paid by pharmaceutical companies for promoting the off-label use of medications. And a majority, I think it's a majority of those cases, have involved psychotropic drugs for people with dementia. So for years, drug companies have illegally been promoting their drugs as a good treatment for people with dementia when, in fact, the opposite is true.
Are there penalties other than what would be probably regarded as a cost of doing business, the fines that you're talking about?
Well, there's certainly civil, so there's, of course, the government can prosecute the pharmaceutical companies. They do that regularly. I'm not sure if those are considered criminal cases or civil cases. My guess is that they're civil cases. But besides that, there's individual cases brought by the victims themselves. Those are always available. In California, in nursing home settings, we use resident rights violations as a potential cause of action. In other care settings, there's the issue of informed consent. And if health care is being given or forced on somebody without their consent, that's considered battery. If consent is obtained, but it's not that informed, meaning that the provider didn't go over risks, benefits, and alternatives that a reasonable person would expect to know or expect to be given by the doctor, that's considered professional neglect or negligence. So that's a potential litigation issue.
If an individual comes across a situation where there is suspected inappropriate use of these kinds of drugs, what should they be doing to address the situation?
That's a good question. So what do you do? I think you hit the books, or the internet in this case. There's so much information about these drugs on the internet. I think it's about asking questions. What is this drug for? And you'd want to do this with any medication, because they all affect body biochemistry in some way, and a lot of times in a significant and irreversible way. So you want to do your homework. What drugs am I on? What drugs is my family member on? Get a drug list. You have the right to that. Take a look at it. Ask questions. Why is my loved one on this? Is there anything that we can do to reduce that? And under federal law, nursing homes especially are required to at least every quarter, every 3 months, take a look at the drug regimen and see what drugs they can pull out of the system in order to improve a person's quality of life. So do the review. What are these for? Can we get them off of them? Ask questions about what alternatives have been tried. Talk about dose reductions and then eliminating the drugs. Take a look at the facility's drug rate on the Canner website. I think that's enlightening. And we actually have a guidebook for consumers and their loved ones called Toxic Medicine. It's also available on our website for free. It's a download. A very informative document. It gives you the background on the problem, the drugs, alternatives to dementia care, and then what you can do directly, what kinds of questions you can ask, and what kind of actions you can take if your questions aren't answered in a satisfactory way.
Yeah, that's an excellent guidebook, and I would recommend that anyone watching this download it and read it, and I will include a link embedded on this page with this interview. If you were to request medical records in a case where someone is suspected of being inappropriately restrained using pharmaceutical restraints, chemical restraints, should you see a review every 3 months? Should there be a note in there that says that the 3-month review was done?
Yeah, it should be there. You should specifically look for evidence of gradual dose reduction attempts or at least considerations. And I would recommend that any resident or family member, and I do this all the time, take a look at records regularly. Even if they're not on a psych drug, I think it's a good idea to see what the staff are talking about, what the care plan looks like, how well it's being implemented. And of course, you're going to be participating in conversations, but I think the records really reflect or give a person a better picture of the type of care that their loved one's receiving. So you want to take a look at the records. Residents have the right to their records. If a resident has a representative making their decisions on their behalf, they have access to the records within 24 hours of their request, and they can get copies as well. Take a look at the records, look at the drug list, start asking questions, and make sure that if they're promising to reduce drugs or eliminate them, that they are in fact doing that.
Okay. And then what phone calls should they be making? Should they be calling the California Department of Public Health, the Attorney General, police? Who should they be calling if they suspect that there's something really wrong taking place?
Well, I would suggest 3 numbers. The first number would be that of the local ombudsman program. Every county has a long-term care ombudsman program. that receives money to advocate for residents in long-term care facilities, including nursing homes. So I'd call them. A lot of those programs are very, very good, and they're pretty well versed on this issue, and can actually, physically go to the facility. That's something that I'm usually not able to do because it's a big state. Second number I would call is the Department of Public Health. There's a local office, a regional office. There's probably a dozen, 15 offices throughout the state. We have information about how to contact local Department of Public Health offices on our website. If you're interested in get them investigating the issue, they can also, physically go into the facility. And then the third number would be Canner's number, our 1-800 number, which is 474-1116. 474-1116. 1-800-474-1116. And ask to speak with me or any of our advocates about your situation.
All right. Well, Tony, I would like to thank you very much for chatting with me about this. It's an extremely serious issue. Is there anything else you'd like to add before we wrap up?
Just one thing. I would say that we've had a lot of progress on this issue as far as national recognition of the problem. A lot of regulatory agencies are now talking about this. A lot of nursing home and doctors are talking about this, but we still have a really, really long way to go before things are clear for residents. So I'd say while things are going good, we can do a lot better, and it starts with each individual saying, no more of this, and asking good, hard questions of their providers.
Thank you very much for chatting with me about this.
You're welcome. Thanks, Jamie.